Um, so the case I'm going to be focusing on today is roxithromycin, and just sort of antibacterials in general, and looking at when to prescribe what when there's a reported penicillin allergy. So this was an antibiotic prescription for an infected ingrown toenail. So my case was a 78-year-old female. So she has had type 2 diabetes since 2017, reports it's well controlled. The main issue in this case was that she was recently diagnosed with early stage dementia just a couple of months prior. She was in this stage where I she was a regular podiatry clinic. So she's been coming to the clinic since 2019. So since I've taken over her case, I've seen her for the last year or two. So when she came in, um, I'd seen her a few times before the infected ingrown toenail, and she was just very confused. I think as well, sort of a bit of the stress and anxiety of being diagnosed with dementia was also playing into it a bit as well. So she was just super forgetful, just would keep repeating herself. And just, I think because she was a bit unsure as well what was going on, it just sort of meant that there was even more confusion in the room. So more recently, she'd also been having issues with ingrown toenail left first. She got a super involuted nail, which is why she was coming in regularly anyway for general treatment. And there'd been times throughout the year where there was sort of mild signs of infection, which we could just get on top of with conservative management. But this time when she came in, it was more those moderate signs of infection. So heaps of pus, red swollen toe, lots of hypergram tissue as well. And when I started asking her about, because in my head I was like, yeah, we need a course of antibiotics. She recalled that she had a penicillin allergy, however, really vague around what sort of reaction it was. A couple of years ago, she said that she developed a rash and there was a bit of swelling, but again, she didn't really seem too convinced. And when I'd asked her about what antibiotics she'd taken since, she knew she'd taken something, but she just couldn't tell me what she was taking. And then when I'd also just asked for an updated medications list, she wasn't able to give that to me again, just super confused, unable to recall what she takes. So in terms of her management, she really wanted to avoid a PNA. So that was sort of first treatment was let's just get this part of the nail out. It's been causing infection for the last couple of months to 12 months. But she just wanted to avoid a PNA, just really terrified of needles and would wanted to do anything she could to avoid that. So antibiotics were really strongly recommended, but due to her being unable to recall her medical history, medications list, and just the uncertainty around what sort of penicillin allergy she'd experienced, we were able to book the client in with the GP the following morning. So even I wasn't even sure that when I was pretty really strongly recommended she see a GP straight away, but I didn't trust that she would leave that appointment and do it herself, or she didn't understand the urgency of it. So we actually called, or I called the clinic when she was in the room. She wasn't able to get in with her normal GP, but we were just able to get her in with a GP at her clinic the following day. So the medication that GP prescribed was erythromycin. So this is in the drug class of macrolides. Comes in capsules, tablets, oral liquid, injection form. However, under the podiatry guidelines, erythromycin is restricted to podiatric surgeon only. And for podiatric surgeons, it's restricted to oral only. So for the purpose of this case, we're going to focus on roxithromycin, which is in the same class of antibiotics. It is formulations of tablets, and there's no restrictions for the endorsed podiatrist. So comes in 150 milligrams and 300 milligram tablets. So the mechanism of action for roxithromycin, it's a semi-synthetic macrolide antibiotic that is structurally and pharmacologically similar to erythromycin. So it's bacteriostatic, so it inhibits bacterial protein synthesis by binding to the 50S ribosomal subunit. They also have immunomodulatory and anti-inflammatory effect. So when we look at bacteria, we know that the different classes of antibiotics will affect them differently. So the penicillins fall under the beta-lactams, and we know that they're bactericidal, so they interfere with cell wall synthesis. And then today, focusing on macrolides, which inhibit that protein synthesis, so down in the bottom right there. As endorsed podiatrists, we also have access to quinolones, which affect nucleic acid synthesis. Just a bit of a short video recap on antibiotics and the different mechanisms of action.
In this video, we're going to talk about the mode of action of antibiotics. So we're not going to look into extreme detail, but we'll just look at the overview. So mode of action of antibiotics. Now we have to know that antibiotics either destroy or slow down the growth of bacteria. So therefore, if it destroys the bacteria, it is bactericidal. If it slows down the growth of bacteria, it's bacteriostatic. Here I am drawing a typical bacteria with cell membrane and cell wall. The wall, cell wall, and cell membrane structure I am drawing is characteristic of a gram-positive bacteria, but we will just assume it is any type of bacteria. Within a cytoplasm, within the bacteria, we have a circular DNA. We can have RNA being synthesized and ribosomes. Ribosomes will synthesize proteins. The first type of antibiotic are the ones that I want to talk about are the ones that target the cell membrane. These antibiotics will disrupt the cell membrane function, which means that they disrupt the phospholipid bilayer. So here is the cell membrane, and here is the cell wall, known as a peptidoglycan. They are different. The antibiotic binds here to the cell membrane. It will alter the cell membrane structure and will make it more permeable. This will disrupt the osmotic balance, causing leakage of cellular molecules, and essentially it will increase the wound uptake, leading to cell death. Examples of these drugs are polymyxins, which I spelled wrong, and polines. Now, polines are actually specifically used against fungal pathogens, but that's just a note that you can use polines to target some membranes in fungus. So polymyxins and polines target cell membranes. Other antibiotic classes target the cell wall. These antibiotics will inhibit cell wall synthesis, so these drugs are therefore bactericidal. They will cause bacteria to die. Example of these drugs are penicillin, cephalosporin, and vasopressin. All these drugs have different mechanisms of action when it comes to inhibiting the cell wall synthesis. A good thing about these drugs is that it won't affect human cells because human cells do not have glycans. We do not have cell walls. Penicillin and cephalosporin have beta-lactams. And then you have the vasopressin and other glycopeptides that prevent the synthesis of cell walls as well. Antibiotics that disrupt the cell wall is pretty extensive, and so hopefully I will make a video on that. Cell walls are important to bacteria. Disrupting a cell wall, preventing cell wall synthesis will result in cell death. The next type of antibiotic class is the ones that can inhibit here DNA synthesis, or what's occurring here, RNA synthesis. So these antibiotics will inhibit RNA and DNA synthesis. So So here, the bacteria are typically having DNA replicated, of course, like so. So we have antibiotics that prevent DNA from being synthesized. These are quinolines and also a class known as nalidixic acids. And then, of course, RNA can be made from the DNA. And there are drugs such as erythromycin, which prevents RNA synthesis and therefore protein synthesis. Other classes of antibiotics also inhibit protein synthesis itself. Protein synthesis is carried out typically by ribosomes, which translate mRNA into proteins. Bacteria need to make proteins in order to survive. However, there are antibiotics that target either the 30S subunit or the 50S subunit of the ribosomes. Erythromycin and chloramphenicol target the 50S subunit of ribosomes, whereas there are tetracycline, streptomycin, and gentamicin that target the 30S subunit. Either way, this will disrupt the ribosomes for making proteins, which will result in the bacteria obviously unable to make proteins. So the bacteria is pretty much useless. Thus, the bacteria can still be alive, but it just is unable to make anything. And so these antibiotics that target protein synthesis are bacteriostatic. They prevent bacterial growth. The last type of antibiotic are the ones that inhibit folic acid metabolism. So normally, this green thing here, called PABA, which stands for para-aminobenzoic acid, it's a precursor to folate. So the bacteria can metabolize PABA into folate. There are antibiotics out there that inhibit folate or folic acid metabolism. See, PABA normally can be metabolized to folic acid within the bacteria. And folic acid, or folate, is essential for the synthesis of adenine and thymine, two of the 4 nucleic acids that make up DNA. These antibiotics, such as sulfonamides and trimethoprim, prevent conversion of PABA to folate and therefore prevent proper DNA synthesis. Humans do not synthesize folic acid, and so these antibiotics are okay to take for humans and are selective towards bacteria. I hope you enjoyed this short video on antibiotics. Thank you for watching.
So back to roxithromycin, indications are for the following types of mild to moderate infections, likely to be caused by susceptible microorganisms. So you've got upper and lower respiratory tract infections, skin and skin structure infections, and when there is a penicillin or a cephalosporin allergy. So in terms of the dosage, adults and children who weigh over 40 kilos are taking a maximum of 300 milligrams a day. So that can be split into a single dose or 2 of 150 milligrams twice a day. And then dose has to be adjusted for children weighing between 6 and 40 kilos. So 2.5 to 4 milligrams per kilo. And again, that maximum of 150 milligrams twice a day. In individuals with severe hepatic impairment, adults are advised to only take 150 milligrams once a day. And it should be taken on an empty stomach, so at least 15 minutes before food or more than 3 hours after a meal. However, there is a note that if you do feel sick and nauseous when you're on this medication, then you can take it with food. Contraindications are known hypersensitivity to macrolides, including erythromycin, severely impaired hepatic function, concomitant therapy with vasoconstrictive ergoalkaloids, which we'll touch on a following slide. And it is safe to use while pregnant and breastfeeding. So side effects associated with roxithromycin It's a generally well-tolerated medicine. A recent clinical trial found that only 1.2% of adult patients had to discontinue the course due to adverse reactions. So the common ones, so less than 1%, it's nauseous, vomiting, diarrhea, abdominal pain, and cramps. Less likely, again, is rash and headache. And then you can see those more rare hypersensitivity reactions below. So some precautions. One's got to do with the macrolide antibiotics, and that's associated with a small increased risk of abnormal heart rhythms, such as QT interval prolongation, which may rarely result in sudden cardiac death. So the risk is increased with patients with other cardiovascular risk factors, and in those patients taking QT prolonging medicines. And then just hepatic, so use with caution in hepatic impairment and to reduce the dose. So the only drug interactions is the ergoalkaloids, and this is a medication that used to be prescribed more commonly for migraines. However, due to its side effects and its reactions with many different other classes of drugs, it's rarely prescribed anymore. But reactions of ergotism with possible peripheral necrosis have been reported after concomitant therapy of macrolides with vasoconstrictive ergoalkaloids. So just something to be aware of when you're taking your patient's medical history. Back to the case, I reviewed this client 1 week following, and she actually had to stop taking the erythromycin as well due to side effects. So diarrhea, nauseous, and vomiting. So she was able to get an appointment with her regular GP, and he actually told her just to stop taking it and didn't even prescribe her anything further. By the time I saw her, the infection had cleared slightly just from taking the couple of days worth of an antibiotic, and it was enough for me to be able to remove more nail. She'd also been soaking the toe in lukewarm salt water daily and using betadine. So it had cleared enough that we could then remove the part of nail which was causing the infection. So it was able to settle down after that. So from this case, some of the key learnings was never to prescribe medication without a current medications list or medical history. And if in doubt, just refer the client to their GP. And always asking about past reactions to medicines, particularly penicillins. Just with the penicillins, especially, depending on what type of reaction it is, it comes with a different risk, and will let you know what then you can prescribe. So this is just taken from the ETG, but it's penicillin hypersensitivity reported by a patient in whom a beta-lactam antibiotic is the preferred drug. So we will just cover some of the different sort of reactions here and what that means. So when we're looking at hypersensitivity, I guess the following definitions is just worth knowing. So a hypersensitivity is a broad term for unpredictable adverse drug reactions. So these can be immune mediated or otherwise. And then a true allergy is an immune mediated hypersensitivity. So the importance of accurate assessment. So many reported antimicrobial allergies, particularly to penicillin, are not reproducible. So over 90% of the reported penicillin allergies are excluded by testing. And childhood reactions are often due to viral infections or mild non-reproducible drug virus interactions. So a lot of the time, people will think they've got a penicillin allergy because of something that happened when they were a child. But if they were to have testing done, it would rule out a true penicillin allergy. So what are the clinical implications of this? So mislabeling patients as allergic can lead to use of less effective broad spectrum antibiotics and inferior clinical and microbiological outcomes. Proper testing ensures patients receive optimal antimicrobial therapy. So when we're looking at the different types of hypersensitivity reactions, we have type A and type B. So type A are predictable, they're dose-dependent reactions. So these are those GI intolerances, feeling nauseous, And then we have type B, which are the unpredictable immune mediated or non-immune mediated reactions. So these ones are taken a bit more seriously. So, and then these can be broken down again into immediate and delayed. So an immediate reaction is something that happens either minutes after taking it or up to 2 hours post exposure. And their symptoms are usually quite severe. So it's usually, this is where there's like an anaphylactic reaction. And just noting there that with anaphylaxis with penicillin only occurs in 1 to 4 out of every 10,000 courses. So is rare, but can happen. And then so with management of these sort of patients, you're just avoiding any re-exposure. You can consider desensitization if critical, but if someone has an anaphylactic reaction to a penicillin, you're not going to re-expose them to it later on in life. And then delayed. So these can occur days after starting the treatment. And it's usually the more they might try this medicine, the faster it will come on. So a common one here is a rash. And then the severe, so these rare but serious syndromes like DRESS, SJS, and TN, these are reactions to medicines where you end up with fever, inflammation of organs, and yeah, super serious ones that can lead to death as well. And then cross-reactivity among beta-lactam. So this all depends on, so the cross-reactivity depends on the R1 side chain. And just, yeah, penicillin and cephalosporins, it's approximately a 1 to 2% true allergy rate. So these were the ETG management recommendations. So take detailed allergy history to assess reaction type and severity, update medical records if allergy is excluded, avoid drugs with similar R1 side chains in known allergies. So, for example, if they've have a severe reaction to amoxicillin, you're going to avoid cefalexin or cephalosporin. And in severe reactions, just avoid all penicillins and cephalosporins. Again, back to my case, my patient had gastrointestinal symptoms. So these were unlikely to be immune mediated, so actually considered non-severe and low risk. So in some cases where a beta-lactam antibiotic is recommended, they could try it again. Other non-beta-lactam antibiotics that my patient could have been prescribed, clindamycin and Cipro, these are medicines that are available to endorsed podiatrists. Hard to know if these would produce similar side effects, considering it was just those GI effects as well. Also, another option could have been maybe a topical antibiotic, so mupirocin, which endorsed pods have access to as well. I had all the information at the time, so her medications list, medical history, and I knew what sort of reactions you'd had to antibiotics in the past. I probably would have then, following the ETG guidelines, prescribed a course of clindamycin. But again, with just everything that was going on, referral to the GP just felt like the safest option. Clinical guidelines and protocols. So in line with the principles of antimicrobial stewardship, prolonged treatment should only be considered with medical practitioner advice. And if there's no improvement or a worsening of clinical signs during the course of treatment, the choice and dose of the agent must be reviewed with referral for further investigation. And as an endorsed pod, we are restricted just to oral use of antibiotics as well. So just to sort of wrap it up, I guess, again, the importance of taking a detailed medical history and medications list, as well as updating this regularly. So always just asking the question in consults, not just when they come in with an infection, but those clients we see regularly, just always asking, have you changed medications recently? Is there anything we need to update on your medical history? And also just liaising with medical practitioners when unsure. So referring them or contacting their GP or even pharmacists. And just the question I wanted to bring to the team is if anyone has come across a case where the client has reported a penicillin allergy, and how you might have navigated that scenario. So now I'll bring it back to the team. I guess, yeah, Chris is probably the only one that might have come across.
Yeah, I think think I probably would have followed it pretty much what you'd done anyway. Like even if with all the information available, knowing that you could prescribe clindamycin, I just think when there's like a mental health condition like dementia or something like that involved, it does get pretty tricky. And I think the more eyes on that person and helping them out, then the better.
Have you come across a patient at all, even like young, healthy, that might have said to you, "Oh, I can't take penicillins." Like I had a reaction when I was a child, or
Yeah. And I think it's interesting, like knowing that the likelihood that that's a true allergic reaction, like a true allergy to penicillin, is super low. As soon as you sort of bring it up, people are not really like people aren't willing to test that theory, even if you do like outlay the facts to them. And I think I probably view Keflex as like, pretty similar in efficacy. So it's always like I just sort of like, well, okay, well, it doesn't hurt to err on the side of caution, and prescribe cephalexin instead. I've never come across anyone who's allergic to cephalosporins or says that they are. So I've never had to navigate that challenge yet.
yeah, I even know this as well. Even GPs a lot of the time will prescribe Kefalexin, even though if you go to the ETG, a lot of the time it's sort of Diclox, Fluclox. Um, but like just chatting to patients, just saying, "Oh, what have you taken in the past?" And it's usually Kefalexin, even if they haven't reported any sort of penicillin allergy. Um, Whereas I don't know, maybe more in a hospital setting, they might be more inclined to actually follow the guidelines and do like a Diclox or a Fluclox. Um,
I often wonder if that's, I know we've sort of touched on it past, like whether or not that's like for safety or whatever, but part of me wonders it too, if it's just even the convenience of you don't have to like worry about taking it with or without food. Like I know
mm,
diclox and flucoxyl like it's a similar sort of instruction to erythromycin. Like you've got to, take it, I think it's half an hour before or 2 hours after. Um, Whereas, cephalexin, you can go for it.
yeah. Anyone else got any thoughts?
Where prescribers go like off script from the therapeutic guidelines, is that like for a case study, is that like the best thing that you can discuss in your case study, do you think, as a bit of advice?
Um, I I think not as part of the process. Like I think it's a great discussion to have,
Hmm.
but only because I did an off script one. Oh, in fairness, it actually did get accepted, I think, from memory. But I know they were pretty much like, um, they did sort of have some feedback being like, oh, when something's prescribed like off script, you have to, discuss it around like high value evidence, that sort of thing. Um, Yeah, but I think something like cephalexin instead of penicillin, I don't think they'd really consider that as off script.
Yeah,
I
I
think
think
as
that
long
would
as
be
you
okay.
acknowledge that, yeah, I think it's probably worth acknowledging it is second line, just being like, oh, in the circumstances, it was, I don't know, for whatever reason, it was deemed. I don't, correct me if I'm wrong, Steph, but I feel like even at some stages last year, you actually couldn't physically get flucoxacillin or dicloxacillin in Australia. I feel like there was a shortage for a period of months as
Oh,
well.
really?
Yeah, I remember when I was looking it up and doing like some of those pediatric, like trying to work out the pediatric liquids and stuff. It was like you actually can't get this, and one of them you can only get in the liquid You can't get it in a tablet form, or maybe yeah, only maybe one of them's in the liquid. Yeah, but there's some weird like caveats around it that maybe influence that prescribing pattern more than the actual um, like pharmacodynamics or dynamics of the drug.
Mm. And actually, V, you'll have to correct me here. There's something really recently came out with an interaction with flu clocks and a really
Paracetamol.
common paracetamol as well.
Right.
Um, which is yeah, super interesting because people take paracetamol all the time. Um, but it's something that they were aware of in like the hospital setting. So didn't prescribe flu clots because of that reason.
Probably has some pretty big impacts for us if, say, we're managing an ingrown toenail or even like post PNA. Like I find these days I tend to, for a PNA, just sort of prescribe or yeah, I guess I could advise them to use the Panadol like prophylactically, just making sure that yeah, they're not if they are taking an antibiotic for those, few days before, few days after, um, that it's not interacting from that point of view.
Mm. Anything else anyone wanted to bring up today?
Steph, have you actually prescribed Roxithromycin or any of those like sort of third, fourth step antibiotics at all?
No. In the back of my mind, I know that clindamycin's, especially with like an ingrown toenail, clindamycin's the next one.
Hmm.
But I've never prescribed it. I think I always just ease on the side of caution. And if there's too many sort of reactions reported and history of hypersensitivity to antibiotics, um, I like to get the GP involved. So yeah, it's usually Diclox, Cefalexin. I don't think I've really strayed away from those. Did you say you have prescribed clindamycin or not? Yeah, no.
No, I'm a bit the same. If there's too many variables, it's yeah, I just refer to the doctor,
Mm,
to their GP. Particularly in Drysdale, it's very comfortable because a lot of their doctors just down the road, so
yeah,
they can usually get in reasonably quickly. Or you can at least have that discussion with them, be like, "Hey, this is what I'm thinking," and they're like, "Oh yeah, I don't have time to see him. I'm happy with that. Like you do it."
yeah. And also just after actually chatting to V this morning, who did some pharmacy placement, V noticed the amount of practitioners, GPs and the likes, calling pharmacists to ask questions, being like, I'm thinking of this script. Like this might be the medical history or these are the medications they're on. And even GPs just calling pharmacists to clarify if a certain script would be okay. So even just giving a pharmacy a call.
That's a great tip, and like, because I feel like a lot of people too tend to stick to like if they're on like a lot of medications that there may be some concerns there, they probably tend to stick with the same pharmacist anyway because they sort of just keep all their scripts there. Um, yeah.
Well, that's all for me. If no one else has anything else they wanted to chat through.
Probably I had a quick question. I because I did my first walk curettage on Monday, and I mixed. This is probably more directed at you, Steph. Sorry, guys. Um, I mixed like a mixed lignocaine with adrenaline. Do you happen to know, like, have you used the adrenaline like and mixed it with just normal lignocaine before? In terms of like, obviously the adrenaline and lignocaine's already mixed, but I think from what Ollie said when he does them, he dilutes them further with more lignocaine. Do you happen to know sort of what percentages he uses or if you've done it
I have
yourself
no
or anything like
idea.
that?
No.
Might have to.
What was the mill of lignocaine with adrenaline and lignocaine. And do you know what the percentage was for the adrenaline lignocaine?
It was 2% lignocaine and adrenaline. I think it was 1 in 800, 80, 1 part per 80 mil. So I mixed. I think I mixed 3 mil of the combo with 1 mil with 2 mils of lignocaine and had 2 syringes. But I only used like 6 mil overall. The maths got pretty tricky when I was working out the MSD.
Yeah. You
But I
really
got
lost me
through it. I was
with
like,
that one.
I was like way under, so that was fine.
Yeah. Yeah,
It
I
was
wouldn't
like a
know.
40-60% split.
Yeah.
Yeah. Because I didn't want to use, because they were only 11, so I didn't want to use full adrenaline and lignocaine. And then I didn't want to mix 2% lignocaine and 2%, like dilute it with the 2%, because I was like, oh, we're probably going to hit. She only weighed like 42 kilos or something. Um, so I wanted to like dilute it pretty much down to like the minimum effective dose I could. So diluting it down with the 1% worked really well. And she couldn't feel anything, so it was fine. And I think we're about 10 mil under the MSD, so it was good.
Yeah, might be a question for Ollie.
Yeah. So I'll have a look, see if I can find any like articles or anything that talk about it as well and report back.
Yeah. Well, if that's it, everyone have a nice weekend.
Thanks, Steph.
Catch you in a fortnight.
Thanks, Dave. See
Thanks.
ya.
See ya.